So it's my pleasure and honor to this night to welcome all of you, my professors and colleagues from Egypt and from Arab world and the other countries and Africa. So this is a unique meeting because it is a special meeting for renal transplantation and for special problem CMV. And the design is today is dependent upon a case-based discussion. So we will start with two cases and then presentation of Dr. Ahmed Halawa. Before the presentation, I would like just to welcome Dr. Tamer Elsalamony, who will present the second case. And this is the photo when I had a look there at Imam Abdurrahman Faisal University. So this is Professor Fahd Al-Muhanna, and we succeeded to establish collaboration with Imam Abdurrahman ibn Faisal University through collaborating with this very kind and legend in the Arab world, Professor Fahd Al-Muhanna and Professor Ibrahim Saeed, who delivered the presentation about sickle cell. Today in this collaboration, we have both Tamer Elsalamony and Hani Mansour. They are candidates in MD Nephrology in Mansoura University in collaboration with University of Imam Ibn Abdurrahman ibn Faisal. We have today's special event because we have Professor Ahmed Halawa. He is well known by his efforts to establish collaboration with his mother country, Egypt, through establishing a program for the care and optimization of a parathyroidectomy for patients whose second hyperparathyroidism is refractory to medical treatment. So this is in Mansoura with Dr. Osama Shahat and Professor Gamal Al-Saadi, Dr. Ahmed Dunya, Dr. Fatina Fadel. In Sohag with Professor Ali Taha. In Aswan with Dr. Hala Al-Abedi, Professor Mai, and Professor Fatina Fadel and Professor Gamal Al-Saadi. And at Urology and Nephrology Center last year, he performed successful 4 cases of parathyroidectomy. They were very difficult, and there was no complication and successfully treated by parathyroidectomy. He established many meetings, Zoom meeting with immune suppression. And one of the very important collaboration step is establishing this common supervision on Muhammad Al-Hadidi. And Muhammad Al-Hadidi returned back to us safely and with a very fruitful and productive 1.5 years under supervision of Professor Ahmed Halawa. We have Professor Qosi as co-moderator for this session. And Professor Qosi is well known by his expertise. He is a senior consultant of nephrology. He delivered many interesting presentations and shared us in cases discussion with Professor Riyad Saeed for 2 sessions. And I'm happy to have him with us today. In this event, as I mentioned, we have 2 cases and 1 presentation. I'm going to stop here to introduce the first presenter, Dr. Dina Abdellatif. Would you please share your slides? Dr. Dina Abdellatif is one of the well-known, she is a consultant and a fellow at Cairo University, and she is well known by her efforts. And she had the chance to, for the international exposure as ESNT fellow since some years. I don't like to say how many years now, but she did.
They all know, yeah, by the way.
Yeah, she did her best to support the society through World Kidney Day activities in many cities in Egypt. Always we like to have Dr. Dina Abdellatif with us because she is also an excellent speaker. Today she will give a case presentation in 15 minutes about the CMV in special situation. We are eager to hear from Dr. Dina her case, and the mic is to Dr. Dina. Please.
Thank you very much, Dr. Hussein, for this introduction. and I'm very happy to be with you today. And I'm very happy also to see Dr. Ahmed Halawa, Dr. Mohsen Al-Kousi, Dr. Tamer Tantawi, Dr. Yasser Abdelhamid, of course, my professor, Dr. Dawlat Bilal. And today we present a case that we saw by the end of last year. She's a 25 years old female patient who was married for 9 years. She has 2 offsprings, and the youngest was 5 years old. Originally, she had autosomal dominant polycystic kidney disease, and she was hypertensive on bisoprolol 5 milligrams. The patient had a preemptive living unrelated renal transplantation in 2015 outside our hospital. She was maintained on tacrolimus, 5 milligrams per day, mycophenolate mofetil 540 twice daily, and steroids 5 milligrams. And on this regimen, she was stable for the past 4 years, and her creatinine, her baseline creatinine was about 0.7. By the end of last year, she presented to our ER with fever for 2 weeks, around 38 degrees, epigastric abdominal pain, persistent epigastric abdominal pain. She had persistent vomiting around 5 to 6 times per day, and diarrhea around 3 to 4 motions per day. On examination, the patient was pale, but she was fully conscious and oriented. Her blood pressure was around 140/90. Her pulse was okay, respiratory rate okay, and temperature was 38, and her BMI was 18. Clinically, she had diffuse abdominal tenderness, and the rest of her examination were all unremarkable. She had a hemoglobin of 8.5. She had leukocytosis with shift to the left, and CRP was elevated to 120, and her tacrolimus level was 12.3 by the time of her admission. Also, her creatinine was elevated to 3.5, urea was 61. Her corrected calcium was okay, and ionized calcium was within normal ranges. She was hypokalemic, and she was hypoalbuminemic with elevated LDH. Her liver enzymes and bilirubin were within normal ranges. Lipid profile was within normal range. We checked her pancreatic enzymes, and her amylase and lipase were significantly elevated by the time of admission. Abdominal ultrasound was done that shows swollen echogenic pancreas with moderate ascites, and her renal graft was within average size and echogenicity, and digestivity index was 0.57 with patent renal pain. Bank cultures were sent to the lab, and the patient started immediately intravenous fluids and antibiotics. And 3 days after her admission, she developed attacks of tonic-clonic convulsions and disturbed conscious level, and she received loading dose of phenytoin and was referred to the ICU. She was on antibiotics that were eventually adjusted according to her cultures, anticonvulsants, and the CT brain was done, and it was free, and her EEG also was normal. Her CMV was checked, and it was positive, and we checked her CSF because of the convulsions attack that she had, and it was free, and we checked for CSF for the CMV, and it was negative by this time. So we had a patient with a fever, pancreatitis. She had attacks of convulsions that were eventually controlled later, and renal impairment. So by this time, we had to put a differential diagnosis for the cause of pancreatitis for this patient. She did not change any of her regimen, immunosuppression regimen, through the recent period. So was it from the cytomegalovirus or was it from any of her medications? At the beginning, of course, we excluded the other regular causes of the pancreatitis, any obstruction, hypercalcemia, hypertriglyceridemia or hyperlipidemia, and they were all okay. So we were left with the cytomegalovirus that was proved positive in this patient and the immunosuppressives that she was receiving. And looking to the literature, cytomegalovirus is pancreatitis with cytomegalovirus has been reported, and it's a known, although it is a rare complication of the cytomegalovirus, but it's reported complication that can go with the cytomegalovirus, and we had several case reports for pancreatitis with cytomegalovirus infection. Looking to the medications that she has been receiving, so according to the criteria for definitive association of any drug with pancreatitis, it has to have the appearance of the pancreatitis during the treatment with the drug in question, the disappearance upon withdrawal of this drug, exclusion of other causes, and the relapse upon re-challenge of the same medication. We have revised all the other medications that she was receiving, and they were all irrelevant and were not, no association with pancreatitis. So we had the tacrolimus, and there were some case reports showing association between the tacrolimus and the pancreatitis, and this was a case published some years ago for a 52 years patient who had a cadaveric transplantation. And 2 years after this cadaveric transplantation, he had acute abdomen and was admitted and diagnosed as pancreatitis, and he was receiving at that time azathioprine, tacrolimus, and minimal doses of steroids. And azathioprine was discontinued, and the tacrolimus was also temporarily discontinued for this patient because of persistent hyperglycemia and hyperkalemia. And after the patient was stabilized, the tacrolimus was restarted once again, and the azathioprine, which is also known, pancreatitis could be a complication, one of its complications. It was stopped, and the patient was shifted to MMF by that time. And after 3 months, the patient was admitted again to the hospital with recurrence of an acute pancreatitis, and he did not make it. And after that, the autopsy revealed that the death was caused by sepsis secondary to the pancreatic abscess, secondary to necrotizing pancreatitis. And so in this case, the tacrolimus was the criminal number one. And this was another case of 45-year-old male patient who had a DCD cadaveric transplantation. He received basiliximab for induction, tacrolimus, MMF, steroids that was gradually tapered to 5 milligrams. And his TAC level was maintained around 10. By the day 67 of his transplantation, he had acute abdomen, and his tacrolimus level was 30 by this time. It was stopped, and somatostatin and fluids and antibiotics were given, and he was shifted to cyclosporin, and there was no recurrence for this pancreatitis again for 7 months until the time of the publication of this case report. Also, there was few reports showing the association between the acute pancreatitis and the mycophenolate mofetil in kidney transplant patients. And this was a report for a living-related kidney transplant patient who was on steroids, azathioprine, and cyclosporin. And his transplantation was going uneventful for 4 years. And then he had a rising creatinine for which a biopsy was done, showing interstitial fibrosis and tubular atrophy grade 2. Cyclosporin dose was decreased because of this IFTA, and azathioprine was changed to MMF. Few months after changing the patient to MMF, the patient presented with abdominal pain, fever, and diagnosed as pancreatitis by labs and CT. He did not survive, and the autopsy findings demonstrated acute necrotizing pancreatitis that were all associated to or referred to the MMF as the new drug introduced to this patient. So by those case reports, I just want to بس broaden كده our the differential diagnosis that we can have different causes for the pancreatitis in this type of patients. We excluded at the beginning the regular causes. Then we were left with the cytomegalovirus with the immune suppressions that we were receiving, but actually her immune suppression, they were not changed for the past 4 years, and the cytomegalovirus was the new incidence that was happening. So returning to our patient, the tacrolimus dose was decreased, the MMF dose was decreased, intravenous fluids and antibiotics were started, and she started ganciclovir in a full therapeutic dose according to the GFR. Her general condition improved. The follow-up CMV PCR was negative, and she was shifted to valganciclovir. The TAC level was around 4.8. The follow-up pancreatic enzymes were normalizing. The serum creatinine returned or normalized, and it was 1 milligram per deciliter, and the patient was discharged from our unit. After 2 months after finishing her valganciclovir, the patient presented to us again, once more. And during this period, actually, she missed her follow-up visits at our clinics. And she came back once more with the fever and with acute abdomen and vomiting. And again, her creatinine was rising to 3 milligram, and she was admitted receiving IV fluids and antibiotics. And again, her amylase and lipase were significantly elevated. CRP was high. Corrected calcium and other labs were within normal. Her cytomegalovirus PCR again was positive, and tacrolimus level was a bit high, reaching 10, and blood culture was showing MRSA. So we are in front a case of recurrent cytomegalovirus and pancreatitis. And here, actually, we were considering that the cytomegalovirus, it's always associated with the higher levels of the tacrolimus levels. So, and she actually missed her, she was missing her follow-up visits during this 2 months. And whenever the tacrolimus level gets higher, the patient had a CMV. Antibiotics were adjusted according to the cultures. Ganciclovir was started for 21 days. The serum creatinine improved and almost normalized to 1.3 with improvement of her amylase and lipase and her general condition. And she was discharged of valganciclovir for 4 months. Unfortunately, after 10 days after her discharge, she returned to us with pancytopenia, with a total leukocytic count of 2.5, hemoglobin 8.2, and platelets of 112. Her creatinine started to creep up to 1.9, and she was readmitted. And the pancytopenia differential diagnosis for pancytopenia was, is it from the cytomegalovirus itself, or is it from the medications that she is receiving at that time? So CMV PCR was tested, and it was negative. The tacrolimus level was 4.2 by that time. There were no signs of our symptoms of pancreatitis with normal amylase and lipase. And her pancytopenia was deteriorating, and she had a neutropenic fever. We stopped the MMF. We stopped the CMV treatment. We decreased the dose of the tacrolimus. We started IV steroids, And she was isolated with antibiotics and antifungals, and after, of course, after the pain cultures. And she was receiving Epogen for 5 days with Tamiflu and Ceptrin. And fortunately, she started to improve, and her pancytopenia started to improve, and the infection markers were improving, and her cultures were getting normalized. But unfortunately, during her stay at the ICU, she developed uncontrolled hypertension, followed by massive cerebral hemorrhage, and actually, she did not survive. So she survived all the infections and all those attacks, and unfortunately, we lost her from another instance. That's all what we have for today. Thank you.
Thank you very much, Dr. Dina, for this case. It is very problematic and very complicated case. Dr. Ahmed, do you like to, the only comment that I have, and then I am leaving the mic to Dr. Ahmed and Dr. Qusi before proceeding to the next case. So we'll hear from Dr. Ahmed, then Dr. Qusi, then the second case, and we'll take the our professors and attendee discussion at the end of the lecture, because I think that Dr. Ahmed will cover some issues. I think the MMF dose that you wrote in the beginning is not 540 milligram. It is 1 gram twice daily. I think this is a missing typing, but I didn't correct it just not to disturb your presentation.
No, that was the dose that she was maintained on.
Because there is no 40 milligram in MMF. It is either 500, 750, 2050. So no 40. It is 500 twice day, or okay. Because 540 is a typing error.
Okay.
Dr. Ahmed?
Yeah, actually, this is a dose of myfortic. This is what I thought. So it's a dose of myfortic rather than MMF.
And not myfortic as well, because myfortic is 180, 360. So it is never to be 540, never.
540?
Yes.
540 and 720.
Yeah. Okay. Okay.
My question actually, Dr. Dina, you know,
it's okay. 180 myfortic plus 360 equal. Yes. Okay.
Yes.
Okay.
Yeah. So
it is mycophenolate sodium, not MMF.
Yeah, it's myfortic. Yes.
Okay.
Yes.
Okay.
Just one question. You never mentioned the PCR value. You said PCR positive. Actually, we need to know the level of PCR, the log, because positive could be just, maybe there's no reactivation. It is just positive because, you know, the donor was positive or the recipient was positive. So we need to know that. The second thing, actually, the explanation of the first case, the diarrhea, the TAC level, high TAC level because of the diarrhea. So when you have diarrhea, most likely the TAC level needs to be adjusted because, you know, the bowel is a secretory organ for CNI. So when we have diarrhea, so the TAC level usually goes higher. Necrotizing pancreatitis is a disease with high mortality. And it's well known that many viruses can cause pancreatitis. So I would think at some stage, if she was suitable, it should have laparotomy and necrotectomy because she presented with acute abdomen. Maybe she was very unwell, not fit for surgery. But anyway, the surgery associated with high mortality, especially with the pancreas, necrotic pancreas in an immunosuppressed patient as well.
But she was improving. Yani she, in both times she improved on the intravenous fluids and on...
The patient improved and CMV, antigenemia disappeared and the pancreatic enzymes normalized. So, and if we discuss this point, Dr. Ahmed, and we'll leave it at the end.
Yes.
It is difficult to agree about laparotomy except if there is clear presentation CT. So it is difficult for me to accept even if there is some necrotizing pancreatitis without collection. But this case, you may be right because there is ascites, but everything improved by valganciclovir.
I am the surgeon here. I'm the only
Yes.
surgeon here. So I have the privilege. Okay. Yeah. Can we proceed for the second case?
Dr. Khosi, just to
sorry.
his opinion about this case, and
Yes.
then go ahead.
Yeah, just two points. As regards the dosing that you have mentioned, mycophenolic acid, which is the 180,
Yes.
65.
Sorry, it was a mistake.
The mycophenolate mofetil will be the 250, 500, 750.
Okay.
The question is, I'm just trying to highlight it to Dr. Dina. Usually after you treat the patient with CMV disease, you just monitor the CMV PCR and you stop the treatment at some point when you are monitoring it to prevent, because this lady has had a relapse of CMV again, as far as I can see from the description that you have mentioned. So have we did the precautions to avoid this relapse by monitoring the CMV PCR after, finishing the course, or you have, on which basis you have stopped the valganciclovir in her case?
Yes, after the initial ganciclovir, she was actually PCR negative. And then she was maintained for the valganciclovir for another 4 months after that. And it was checked 2 times and the PCR was negative.
I see. And in the other time when you've just, developed the pancytopenia, has she been on mycophenolate and the valganciclovir, or she has been on mycophenolate only?
No, mycophenolate and the valganciclovir.
Because usually with the pancytopenia, it's a common, or recognized side effect anyway. And usually what we do, we stop the antimetabolite, the mycophenolate initially, and see how it goes. If it didn't work, then we stop the valganciclovir if the patient has got CMV disease. So I don't know whether you have stopped both of them at the same time, or you have stopped the mycophenolate.
So initially,
in the management.
Initially, we stop the mycophenolate, and this is the first thing that we stop. And then we, if the patient is not improving, we stopped the rest of the treatment, the
valganciclovir.
Yes, the valganciclovir that she was receiving. And actually, we decreased the doses of the tacrolimus at that time, and we increased the dose of the steroids, and the patient was improving actually.
And the cerebral hemorrhage was definitely because of the severe hypertension or malignant hypertension.
That's the explanation that we had. Yes.
Right. Okay.
That's the explanation that we had. She was at the ICU at that time, and she had and her blood pressure was elevated, and this was the explanation.
No DIC, no clotting problem. No, nothing.
At that time, her pancytopenia was improved, and her inflammatory markers and her CRP was going down. It was just 16 by that time. So actually, her infection and her pancytopenia had improved by that time, and then there was another new incident that happened for this patient.
Thank you. That's good.
Dr. Ahmed, Dr. Dawlat Bilal just want to comment. This is a complicated case. This is why my mind is to give just 2 or 3 minutes for some to raise some point, because it is not a straightforward case. Dr. Dawlat? Unmute yourself, Dr. Dawlat.
Thank you to Dina for the nice case. But what I would like to mention in the first time when the patient developed the CMV, I think the first line of treatment is to hold completely the antimetabolite. So even before we start the antiviral treatment, it should from the start to stop completely the Cellcept before we continue the other line of treatment. And then not to restart again until we are sure the CMV PCR is negative for 2 times. This is my comment.
At the beginning.
I prefer to stop the discussion at this point, because I think Dr. Ahmed will cover some points regarding the manipulation of immune suppression management, and then leaving the question at the end to have a spicy discussion with Dr. Ahmed Halawa. Thank you very much, Dr. Dina, for this very complicating and frustrating case, but
Yeah.
this is life. We may have severe case that we cannot save her. Thank you very much for your
Thank you.
presentation.
Thank
And
you.
I think Dr. Ahmed will add some points in his discussion. Dr. Tamer Elsalamony, where is Dr. Tamer? Dr. Tamer Elsalamony, please share your slides. Unmute yourself and share, yes. Dr. Tamer.
مع حضرتك يا فندم.
Okay, open the slideshow and strict English, please. Tamer.
حضرتك سامعني؟
Yes, it's okay. Dr. Tamer Elsalamony is one of the very active doctors. It was my pleasure to have Dr. Tamer with us for 4 years before he left to Kingdom Saudi Arabia for I think 8 years now, Dr. Tamer? 9 years in Saudi Arabia. He is very, I visited the hospital there and established the collaboration with Professor Fahd Al-Mahanna, and he is now a candidate of nephrology under common supervision by Professor Fahd Al-Mahanna and our site here. He is very active, enthusiastic, and I witnessed her sincere work there. So, and he will discuss a case under the title of a case of CMV colitis. Dr. Tamer.
Thank you, Dr. Hussein. It is a great pleasure to be with you all today.
Okay, go ahead.
A 36-year-old Saudi female patient, not known to have any medical history before, accidentally discovered end-stage renal disease on December 2009. She underwent for living non-related renal transplantation outside Saudi Arabia in 2011. She was maintained on steroid tacrolimus and filter. There is no enough details about the donor or the surgical process. She experienced a smooth early post-operative course according to her. In 2013, she was presented to our hospital for the first time with diarrhea that required admission. Diarrhea was frequent more than 4 times a day for 5 days. Watery, no offensive odor, and not accompanied by blood or mucus. Examination at that time, blood pressure was 100/50, pulse 90, respiratory rate 18, temperature 36.7, looks dry, ill, pale, not in respiratory stress, dry tongue, sunken eyes. She lost her weight about 3 kg in 1 week. Local examination was normal. Investigation revealed acute graft impairment. Creatinine was about 2.2 milligram per deciliter, BUN 25, mild hypokalemia and acidosis. Mild leukopenia, WBC was 3.1, hemoglobin 9, platelet 170, liver function test was normal, stool analysis and the culture were negative. CMV, IgM, and PCR were negative. Colonoscopy done also at that time to reveal mild chronic non-specific colitis and gastritis. Management was by IV fluid. We hold the filtrate temporary, and she was maintained on tacrolimus and steroids. She recovered, diarrhea stopped, and discharged. My fortune started in the clinic in the state of filtrate. She was maintained on creatinine about 1.2 milligrams during the follow-up in the clinic, with intermittent bouts of mild diarrhea managed consecutively by increased oral intake and the temporary holding the myfortic. In 2015, she experienced another attack of non-blood diarrhea with offensive odor, with another acute graft impairment. Creatinine was 2.6 milligrams, BUN 35, hypokalemia and acidosis. Stool culture revealed the clostridium deficit. CMV, IgM, and PCR were negative. Management was by IV fluid, oral vancomycin, and metronidazole. We hold myfortic temporary also. She recovered, graft impairment improved, myfortic resumed in the clinic. Her basal creatinine was around 1.6 to 1.8 milligrams. From 2015 to 2020, she was admitted many times by frequent attacks of diarrhea with negative investigation regarding the stool or the CMV profile. During one of these attacks, she was shifted from myfortic to idathioprine, but unfortunately, she developed acute pancreatitis, so we returned her back to myfortic. In June 2020, she was admitted again with severe diarrhea and acute on top of graft impairment. Creatinine was 3, UN 35, hypokalemia, and acidosis. All the available diarrhea workup done, stool analysis and the culture were negative. CMV, IgM, and PCR were negative. Colonoscopy done to reveal large bowel mucosa with mixed inflammation, glandular injury, and viral inclusions consistent with CMV associated colitis. So the diagnosis of CMV colitis was established. We treated her we discontinued the myfortic, we continued on steroids and tacrolimus, and started oral Valgan cycloprid. This month, in August 2020, in the clinic, she's clinically stable, no diarrhea, she gained her weight, creatinine 1.7 milligrams, UN 25, improved the hypokalemia and acidosis. Liver function test was normal with mild leukopenia around 3.4. Briefly on gastrointestinal tissue invasive disease is defined as CMV disease with symptoms localized to the GIT tract. In the general population, tissue invasive gastrointestinal CMV disease almost always occurs in patients with relative immunosuppression due to critical illness or comorbidity, such as diabetes, renal insufficiency, pregnancy, autoimmune disorders, heart failure, or malignancy. The GIT tract is most commonly involved and comprises about 30% of the tissue invasive disease. Among the tissue invasive gastrointestinal CMV in this population, the colon is the most frequent reported site of involvement, comprising about 94% of cases. Symptoms and signs: fever, anorexia, weight loss, abdominal pain, nausea, vomiting, diarrhea, and the hemorrhage can otherwise be present with involvement of any part of the GIT tract. Endoscopic findings also range from mucosal inflammation to edema to pseudotumors and severe ulceration. Diagnosis of tissue invasive CMV requires the histopathological demonstration of CMV involvement of the suspected organ. Cytopathic effects such as inclusion bodies are seen in only 65% of the cells that can stem positive with CMV immunohistochemistry. This led to Ann Miles in the American Journal of Surgical Pathology in May 2013 to add mucosal PCR to the diagnosis, declaring that both techniques are complementary to each other. Approximately 10 to 15 of diagnosis missed by one modality can be detected by the other. A negative plasma or whole blood PCR doesn't exclude tissue invasive CMV disease, especially in patients with CMV gastrointestinal disease, pneumonitis, or retinitis. The absence of CMV inclusion of histopathology also doesn't exclude tissue invasive disease, since such inclusions can be made as a result of sampling error. In some patients, it may not be possible to obtain a tissue biopsy, so when this is the case, viral load testing or culture body fluids may be performed. Treatment: GAN-cyclovir oral bioavailability is 6.9%, and therefore oral GAN is not recommended for treatment of CMV. The L-vinyl ester approved drug of GAN-cyclovir, Valgan-cyclovir, has an oral bioavailability about 61%, which improved by 25% if taken with food. Clinical trials in AIDS and solid organ transplantation, patients have demonstrated comparable efficacy and safety between IV GAN and oral Valgan-cyclovir with treatment efficacy of over 80%. Take-home message: CMV disease can occur late in kidney transplantation. Negative CMV PCR cannot rule out CMV disease. Histopathological diagnosis of CMV can be negative due to sampling error. Negative CMV PCR disease can be monitored only by clinical tests. Thank you.
Thank you very much, Dr. Tamer, for this case. It is also a complicated case. And I think a lot of points will be discussed by Dr. Ahmed Halawa during his presentation, because I think this is one of the main points of his presentation: tissue invasive CMV after transplantation. Only one point, and this is a very problematic and very, I don't like it. When we have a case transplanted, we should give her report. And the point that the patient doesn't know the details, no reports about the transplantation, the state of the donor. So this is the quite problem. And even if she is was transplanted in our country, this is the point to be raised. If the case is transplanted everywhere, this is one of the ethical point and the right of the patient to continue her care, to give her detailed reports about the essential data, complications, and the management done. But the case is full of many points. Today, it is different from Dr. Faisal opened the camera for discussion. So we'll take one comment from Dr. Faisal and then go ahead to the lecture, because today it is different from any case presentation. We have a presentation that may answer many questions. Dr. Faisal.
Thank you very much. Actually, I have a comment, just like you, that we should know about CMV before transplantation, because this will affect our management. And the two cases are very interesting, very rare cases, but still, if we know in the previous CMV, probably we can do a prophylactic for longer time, or at least we can manage them very quickly. I agree with you that the living unrelated transplantation make a lot of problem for us as well, because many patients get such infection and we don't know anything about them before transplant.
Okay, thank you very much, Dr. Faisal. And I think it is unethical to conduct such a surgery without giving report to the patient. It is mandatory for any intervention to be reported to the patient, even if in a summary way that can help in the continuity of the care of the patient, even if it's treated by another physician. This is one of very important point. Do you have Dr. Al-Qousi with us? Dr. Mohammed Al-Hadidi, please unmute Dr. Al-Qousi. Dr. Al-Qousi. Unmute yourself, Dr. Mohsen. Dr. Mohsen, unmute yourself.
Yes, I don't have a comment. I mean, thank you very much. Interesting case as usual. And the tissue invasive CMV, we will learn now from Professor Halawa about the validity of the CMV PCR in colitis, retinitis, and pneumonitis might not be working at all. And we have to rely on the tissue diagnosis.
And even if we take the case as a case of diarrhea, this is the point that we learned from the recommendations, because Dr. Halawa wrote a special issue of the Journal of Egyptian Society of Nephrology and Transplantation. It was a fantastic issue because it includes all infections after transplantation. One of the special cases, if we have diarrhea, we don't know is it CMV or others. And we shouldn't assume that every case of diarrhea is CMV. Yes, it is one of the differential diagnoses, but we have, and this patient, weight loss and the symptoms, we should exclude other causes, including malignancy, other infections, and before giving a stamp of CMV. And as well for MMF or mycophenolate sodium, we shouldn't say is diarrhea related to MMF or mycophenolate except after thorough investigation. Because there is, in the biopsy, in the pathology of the intestine, we may find villous atrophy, denoting mycophenolate, because mycophenolic acid, which is the product of mycophenolate mofetil and mycophenolate sodium, leads to atrophy of the small intestine. So this is why we shouldn't be in rush. I remember a case of Professor Saeed Al-Ghamdi during one of our CME transplantation courses. The diagnosis was established only after doing colonic biopsy, and the colonic biopsy revealed the organism in a culture. So we shouldn't take it lightly to respect the clinical presentation and to do the investigation. Dr. Yasser Abhamid, 1 minute, and Dr. Riyaz Saeed, 1 minute, and then we start the presentation.
Less than 1 minute. I want just to get two clarifications about the use of oral vancomycin. Did you use the oral vancomycin assuming for non-specific colitis or assuming pseudomembranous colitis?
No, I believe that he mentioned that C. diff positive. He was C. diff positive, and I believe that he has taken the oral vancomycin because of the C. diff rather than anything else, as far as I understand.
Okay, I want to get clarification for this point. What was positive, huh?
Yes. I believe so. I mean, you can ask him. He can.
Dr. Tamer.
Dr. Tamer, please.
It was positive.
Yes.
Okay. The second point,
this is a nice point to have all the investigation available, and the oral vancomycin is fantastic. There is no form, there is no tablets. It's just the ampoule of vancomycin.
Just the ampoule.
Yes, yes.
Yes, Dr. Hassan.
Do you have it in tablet, Dr. Qusi? Because we used it for a couple of cases. Just the ampoule is given oral.
We give it all for the resistant C. diff for metronidazole. If they is metronidazole, we give oral vancomycin 125 4 times a day for 14 days.
It is the same response?
Dr. Yasser Mullah wrote here, it is available as capsule now as well.
Yeah.
We don't have it in Egypt, except in ampoule. So this is what we do. It's giving it oral.
Excuse me again, Dr. Hussein.
Excuse me. اتفضل.
Dr. Qusi, please, have the same response, oral metronidazole and oral vancomycin?
No. What I'm saying is, usually we start with the metronidazole. If the patient didn't respond after 10 days to 14 days of metronidazole, we go for the vancomycin orally at 14 days, 125, 4 times a day, and then we gradually wean the vancomycin.
Step by step, not choices.
Yeah.
Yes. My second clarification, please. Was CMV PCR positive at the time of colonoscopy and biopsy or later on?
Dr. Tamer.
It was
negative.
Negative.
It was negative.
It wasn't positive at all. All negative.
Negative.
All negative at the time of the biopsy. At the time of the colonoscopy, it was negative. Okay.
Yeah.
Okay. Thank you.
Thank you.
Thank you.
Yasser. Dr. Riyad Saeed, and then we'll go to the lecture. Dr. Riyad. Please unmute yourself, Dr. Riyad Saeed. Okay, Dr. Halawa, you can share your slide.
Okay, do you mind just, I have a few comments on Dr. Tamer. It's important before I proceed further. It looks like you and Professor Faisal Shaheen have read my mind. Both cases look like illegal transplants. Donors are known outside Saudi and outside, or unrelated in the Egyptian one. So, of course, you will never get any report of illegal transplants. And this shouldn't happen in the first place, but it's still happening. We can't stop it. But at least, as you mentioned, we have to have donor details, and even if it's illegal, because we are in dilemma with the donor positive or negative. It makes a difference. And this is actually, I'm going to show how different can make in my presentation. The second thing, actually, PCR positive doesn't mean anything to me. I need to know the level, how many logs, because you're not treating properly unless you know the level or how many copies. So we need to know how many logs. And the idea of having logs to avoid, big number, 3,725. No, we can say there are 3 logs, more than 3 logs. The third thing, the comment I would like to make to Dr. Tamer, with all respect, we shouldn't mention the nationality of the patient by all means. We should have no identifiable information by all means. It's part of our culture, but we have to change. So a female patient, full stop, rather than Saudi, Egyptian, whatever, no identifiable information. Shall I start my presentation? If you can allow me to share slides.
I agree with you, Dr. Ahmed, regarding the all points you clarified. Mm-hmm. It is essential to have the detailed, even if it is endoscopy, not transplantation. And the details of transplantation is essential and mandatory. The second point is, as you mentioned, I don't want to know the nationality, except if it aid in the diagnosis and the management. So long as it is unnecessary, it is unnecessary, because here we are not filing the patient in the system, because in some places, if the patient is Saudi, the patient will be insured. If it's not a foreigner, there will be a nice dealing, another dealing. So this is not essential at all for the clinical presentation discussion in the
It's
meeting.
not medical, yes, I agree.
Yeah, and I remember the House Officer book from UK. They put rules even for a case presentation when we have a real clinical round in front of the patient. I like this way, because if I am making clinical round with Professor Faisal and I'm presenting the case, Professor Faisal see the patient male or female, it doesn't matter. It doesn't add anything to say it's male or female patient. Second point, the race. How can I say this is Negro, this black patient? It is unethical at all. So sometimes there are data that's even unnecessary when we're dealing with the patient. So we should respect all these points. I think because of the time, it is my pleasure and honor to introduce or to invite Professor Ahmed Halawa. He's a well-known figure and he's unique. He's surgeon in Sheffield and educator in Liverpool, associate professor in Liverpool, and a consultant transplant surgeon in Sheffield. So this, I think it is unique. I don't know any professor or any surgeon who is working in two universities in the same moment. His clinical work in Sheffield, and he is responsible about transplant education in Liverpool, and he is the director of Master of Renal Transplantation at University of Liverpool. So it is a real pleasure and honor to have this with us today to speak about very important issue, one of a very important issue, because as I'm going to discuss with him in the discussion sector, we have bad times with CMV since a decade or more, because at Urology and Nephrology Center, Mansour University, our policy was not to give at all prophylaxis. But during the journey, we had bad pneumonias in some cases. Some of them died. So since many years, 10 years, we started to think of prophylaxis. And I'm going to say our protocol, because we have unique protocol, because of we are of limited resources, at the end of the presentation of Dr. Ahmed Halawa. It's my pleasure, and the mic is to Dr. Ahmed Halawa. Please start sharing your slide.
If you allow me to share my slide.
Yes, it's allowed. Share your slides.
Open system preference.
It's done.
Okay. So sorry for this technical problem, and then the mic is to Professor Halawa to start his presentation.
Thank you very much, my colleagues and friends. CMV is a disease which can kill. It's a viral infection which is associated with morbidity and mortality. As you can tell, it's not only the kidney which get affected. CNS, you can get CMV encephalitis with high mortality, retinitis with high mortality, but fortunately enough, both CNS and retinitis not actually common in renal transplant, usually HIV patients. Pneumonitis was associated with mortality, myocarditis, gastritis, pancreatitis, as we discussed, colitis, and GIT CMV, cystitis as well. So we have to think of CMV as a multi-system disease. I would like to refer to these guidelines. It is just reference to the guidelines, but just hang on a second, you are running, yeah.
No, I'm not running. You have here the rehearsal and the time is saved. So I'm trying just to stop the rehearsal. Okay.
Okay. Yeah. So the guidelines, this is published in 2019, just guidelines. What I'm going to discuss is how we manage tissue invasive CMV based on our practice in Sheffield with reference to some guidelines. So diagnosis of CMV disease. I won't go down to the definition of CMV infection, CMV disease, syndrome. what's more important today is a tissue invasive CMV. We need to understand how to diagnose tissue invasive CMV. This is actually what Dr. Tamer said. You know, summarize it nicely. Tissue invasive CMV, you need to demonstrate the virus itself in the tissues, not the signs of the virus, not the organ dysfunction. Let us say if you got hepatitis, you need to demonstrate the virus in the liver tissue rather than having raised liver enzymes. Raised liver enzymes could be due to any other reasons, not necessarily directly related to the CMV. Does CMV actually matter? Yes, it does matter. If you notice, this is an old reference, more than 20 years old. It's been documented very clearly that CMV is associated with increased incidence of rejection. What about graft survival? Again, the same reference, 1993, showed diminished graft survival for those got CMV. So CMV actually does matter. Risk factor of CMV-associated disease in solid organ transplantation. I brought this slide for a few reasons we mentioned early on. Donor-recipient status. In the cases presented early on today, we don't know anything about the donor status. Also, the recipient status is important. It should be part of the workup. We need to know whether the recipient before we start is positive or negative. Being positive or negative, had he past infection in the past or not? You will discover that when we get older, more likely to have CMV antibodies, IgG. It is age-related. And this is important for counseling patients, because if you're transplanting highly sensitized patients, immunologically high-risk patients who are CMV negative, and you got a donor who is CMV positive, so most likely this patient will be treated for rejection, who may have rejection. Could be aggressive treatment, giving his seronegativity status, and the donor seropositivity may put him at risk. So this is part of counseling. You can tell clearly here that the kidney at the bottom of the scale, the type of organ transplantation. Heart, lung are the worst. Immunosuppression. We used to mention as a part of treatment, we reduce anti-metabolite. It's not the anti-metabolite which causing the trouble. It's the magnitude of immunosuppression, the holistic immunosuppressive status of the patient. So no single drug is incriminated of causing the disease. Is the whole package. Degree of HLA mismatch. Why it is important? Because actually it's related to the amount of immunosuppression the patient is receiving. If you have full house mismatch transplant, most likely you'll have augmented immunosuppression. Most likely you will reactivate or super infect or primary infect him with CMV. So we have to have a holistic view about the donor and the recipient. Indirect effect. CMV being accused of causing chronic allograft nephropathy. Remember, chronic allograft nephropathy is a term which could be obsolete now. Chronic graft injury. Heart transplant vasculopathy, which is similar to chronic damage of the graft. New onset diabetes and renal transplantation associated with CMV infection. Cardiovascular risk after transplantation even as well with is higher in CMV positive patients. Hepatic artery thrombosis after orthotopic liver transplantation. Prophylaxis. Professor Hussein mentioned actually, they were not keen on prophylaxis, but the change, since we have many fatal CMV pneumonitis, we thought about prophylaxis. Yes, I absolutely agree with him. CMV infection without prophylaxis could happen in 80% of patients, with mortality up to 80%. Remember, this mortality is higher than the coronavirus mortality. This is addresses the importance of prophylaxis. We shouldn't undermine it. By all means, it's an essential part of the treatment. I received second opinion from many colleagues, and I discovered they are reluctant to put patients on prophylaxis. It is a standard treatment, part of the package. This is a virus which can kill. The prophylaxis usually for 3 months, 100 days. And this is actually was the initial plan, but we discovered later on, and I'm going to describe briefly the impact study, that is still happening after stopping the prophylaxis for 100 days. So it's better to extend the prophylaxis for high-risk patients. But there is a resource constraint here because the drugs are not cheap. Valganciclovir is quite expensive. The prophylaxis, just briefly, ganciclovir, valganciclovir, we're not using them quite often for prophylaxis, but we use oral administration of valganciclovir. The oral ganciclovir have limited bioavailability, which is one of the important points addressed by Dr. Tamer. 6 to 9%, as you mentioned. Yeah, 6 to 9%. I would like to ask you, what's bioavailability here? What's meant by bioavailability? If you look at it in the textbook, it will tell you something stupid, to be honest. It will tell you it is a degree of exposure. It's the area under the curve. What does it mean? How would you translate it in clinical understandable terms? So basically the bioavailability, if you consider the intravenous dose, bioavailability is 100%, and it should be 100%, the level after oral dose divided by the expected level of intravenous dose gives you the bioavailability. So bioavailability of valganciclovir is much better. However, we need 100%, it's never 100%, but for severe life-threatening CMV infection, we use intravenous to achieve 100% bioavailability. Dosing. These days, you don't need to remember the doses very much, especially with drugs regulated, dose controlled by the renal function. But generally speaking, the ganciclovir 5 milligram per kg, the ganciclovir 900 milligram by mouth daily, adjusted for the renal function, talking about prophylaxis. Monitoring. The worst side effect of valganciclovir or valganciclovir or anti-CMV is neutropenia, anemia, thrombocytopenia, blood. And again, should be adjusted for renal function. There's a trick on the renal function here. I'm going to mention it later. CMV immunoglobulin is written in the literature, can be used for prophylaxis, but very expensive, not always available. We used it once for resistant CMV infection, so as a treatment, but not for prophylaxis. But it's written in the textbook. It can be, it's academic basically, not practical, and also limited data to support the use of prophylaxis. Next. Late onset CMV. The importance of knowing the donor and the recipient CMV status, as addressed by Professor Hassan and Professor Faisal Shaheen, is entirely important, because the D positive, donor positive, recipient negative, more likely to get recurrent CMV after stopping prophylaxis. They reported up to 30%. In Sheffield, before we extended the prophylaxis to 200 days, 6 months, we have done audit to see whether we have recurrent CMV after stopping prophylaxis for 100 days. Well, yes, there's a significant number, but apology, I couldn't remember the figure. But based on this audit, we extended the prophylaxis to 200 days. For those who are donor positive, recipient negative, and those who received strong induction immunosuppression. And this is the impact study. The impact study showed that it is valuable to extend the prophylaxis to 200 days. Next. You can tell clearly that if you extend it for more, less infection you get. But I would like to remind you that the impact study was sponsored by Roche, the one who was selling the Valgan cyclovir. But no evidence, no supporting evidence from their data that there is associated, there's increased incidence of rejection and significant difference in graft survival. Next. But if you notice here, graft loss, however, is not significant, but this is clinically significant, double. But anyway, let us stick to statistics. Next. The impact study reported the common side effect is leukopenia. It can cause anemia and neutropenia as well. Loads of side effects. Next. So the conclusion of the impact study is to extend the prophylaxis to 200 days. Even more would be better. And there is no increased incidence of graft rejection or significant difference in graft survival. Next. Next. So, again, when I commented on the PCR, we need to know the level. Because look to number 2 and number 3. Consider treatment when the viral load exceeds 3 logs. So to me, positive PCR does not mean anything. It could be 1 log. And I will tell you why later on. Treatment is mandatory when it reaches 5 logs. But don't forget, you could get symptoms in 3 logs. So you have to start treatment. You could have tissue invasive with 3 logs. You could start treatment. You will never get 3 logs unless you know the level, the copies, how many copies. Next. Fine. We're talking about treatment. The treatment, do you think we should be rushing into antiviral treatment? the antiviral treatment wouldn't work with augmented immunosuppression. So we have to reduce the anti-metabolite. Why the anti-metabolite? Because they are weaker, because the kidney can survive on C9, hardly survives without rejection on anti-metabolite. We continue steroids. We keep monitoring the PCR, how many logs, how many copies. The treatment should be continued till CMV, DNA, PCR is no longer detectable in the plasma. Once or twice? No, twice. After 2 negative PCR and minimal treatment of 14 to 21 days, negative 2 PCR, we can stop treatment. But we're stopping treatment. Will you continue prophylaxis? Yes, you continue prophylaxis after stop treating acute infection. Next, please. This is what I mentioned earlier on. If you have a severe disease, we prefer in Sheffield, start IV ganciclovir. Why? To achieve bioavailability. Remember, the oral ganciclovir bioavailability around 6%. And the dose, as I mentioned early on, until we get 2 negative PCR, and then we continue on prophylactic dose. Next, please. Monitoring CVR by PCR is essential. But don't forget, we have to reduce immunosuppression as well. And what about if you have immunologically high-risk patients? So I'm playing with immunosuppression. I'm giving him an nephrotoxic drug. How would you manage? You could be rejecting as well, because CMV, as I mentioned, can induce rejection. In this case, you could give both together, intravenous steroids in addition to intravenous ganciclovir. Next, please. I would like to just to highlight the VECTOR study, published 2007, an old study, but it's non-inferior study. It showed that ganciclovir is as good as, is not inferior to ganciclovir. But if you look at this study, they use mild and moderate cases, not severe one. So don't be biased by articles without critically appraising the article. To know what are their selection criteria and exclusion criteria, inclusion criteria, exclusion criteria. Don't take the message blindly. So ganciclovir is non-inferior, is equivalent to ganciclovir in mild and moderate. Next. And this is a trick, and this is what we have here in Sheffield, and I think Professor Kos is aware of that as well. Dose adjustment based on renal function. The table we have, if you look down there, is creatinine clearance, not the GFR. Be aware, I'm sure you will be better than me, that creatinine clearance overestimates the GFR. Anyway, and this is what we have. Adjust ganciclovir and ganciclovir based on the creatinine clearance. Next. Ganciclovir resistance. Again, back to square one, I need to know the log. because the definition of resistance based on the log. How many logs? 1 log copies. No improvement by 1 log copies means resistance. Or clinically, no improvement failure, no improvement success. There's no improvement at all. Still having symptoms. But before we rush into ganciclovir resistance and label the patient resistant to ganciclovir resistance, we should exclude other causes of the symptoms. Why his kidney function is deteriorating? It could be rejection as well. It could be just simply dehydrated, because you know the cases that presented by Dr. Dina and Dr. Tamer, there were evidence of dehydration. Also, it could be evidence of other infection, not necessarily related to CMV, directly related to CMV. Don't forget CMV as immune modulator. In addition to the direct effect, it can immunocompromise patient further. This is why you get rejection. Also other infection and even malignancy as well. Switch to foscarnet. Next. Consider further reduction of immunosuppression. But foscarnet is not lollipopies. It's not an easy drug to use, associated with side effects. And this toxicity limited its use for long term. A lot of colleagues might think of leflunomide is effective. Actually, the studies didn't show that leflunomide is effective. It's weak immunosuppressive drugs used by the Americans most of the time. It's already written in their protocols, but all the studies didn't show that leflunomide is effective. Sidovert, again, is not effective. As I mentioned, CMV immunoglobulins, if it's available, we used immunoglobulin once in resistant CMV and it did work. But what we use is not CMV IVIG. We use IVIG itself, hoping it worked, and it did work. Next. Fine. This is purely academic. Just this slide back again, please. This is purely academic. And the next slide, thank you very much, is again, is still academic. So the resistant CMV is genetically determined. You look for some viral mutations related to the kinase and polymerase. Genetic studies. To be honest, and to be clear with you, we never did it in Sheffield because we know the genetic workup takes a while. Patient could die before getting the results back. Again, adoptive immunotherapy being tried recently, but not in kidney. You can tell here, this is bone marrow transplant, phase 1 clinical trial. We have to think about it. It's all about T cell, functioning T cells. So transferring functioning T cells. Improving the cytotoxicity of T cells. Next, please. Again, the adoptive immunotherapy is successful. Next, please. Fine. So back to the tissue invasive CMV. Diagnosis of gastrointestinal CMV and imperfect science. Never been perfect science. Next. As my colleague, Dr. Elsalamony mentioned, the gastrointestinal tract is a common site of tissue invasive CMV. And the point is, up to 20 to 30% of CMV colitis and CMV gastritis, and subsequently, in the next few slides, CMV pneumonitis, PCR is negative. How would you diagnose it? By colonoscopy and biopsy, and even PCR of the biopsy sample. Tissue invasive CMV is associated with invasive investigation, colonoscopy, gastroscopy, biopsy, bronchoalveolar lavage. Next, please. Here's some figures for those who are interested in figures. So the quantitative PCR had 85 sensitivity and 95% specificity for diagnosis of CMV, gastrointestinal disease. 85 sensitivity, never been 100%, all right? But the sensitivity is higher for those we know that the donor is positive, recipient is negative. Again, I'm back to square one again, which the donor serostatus should be known. This helps us in the diagnosis. For liver transplant, sensitivity is higher, but we're not dealing with liver now. Next, please. CMV colitis, exactly like what Dr. Tamer presented. Diarrhea, abdominal pain, fever, commonest presenting symptoms. Could be blood in the stool as well. Should I rush colonoscopy and biopsy and the D positive R negative? Of course not. Why? It could be just simple bacterial infection. Could be other viral infection, not necessarily to be CMV. Stool culture, C. diff toxins, norovirus is quite common in the UK, and many other parasites can cause these symptoms. Or could be a side effect of immunosuppression. MMF, mycophenolate mofetil, is a very common, very friendly immunosuppressive drugs we use these days. The commonest anti-metabolite we use. There could be side effects to the MMF. So we have to exclude this first. Next, please. And this is a picture which is basically non-specific. You can tell this CMV colitis, inflammation, inflammatory mucosa, as you can see, to some extent polyps on the left-hand side. And this is a tissue diagnosis, which is next one. What you need is giant cell with inclusion bodies characteristic of CMV colitis. This is the one here. Fine. CMV gastritis, again, similar symptoms, but symptoms related to the stomach, epigastric pain, vomiting, diarrhea. Gastroscopy, you find erosions, ulcers, inflamed mucosa again. But if you have noticed here, yes, giant cell with inclusion bodies. Next, please. CMV pneumonitis. This is associated with high mortality. Again, it could be present with symptoms similar to bacterial and other viral infection. Instead of rushing into bronchoalveolar lavage, we need to exclude other infections. Simple sputum culture, chest X-ray, even chest CT scan. But remember, CMV pneumonitis as well could present with negative PCR. So this is, as I mentioned, the sensitivity of PCR in tissue invasive CMV never been 100%. It's 85%, could be down to 70%. So 30% of patients will have negative PCR. The treatment for CMV colitis, pneumonitis, gastritis is similar to a severe CMV I mentioned earlier on, which we give 5 days IV course and then followed by oral valganciclovir till 2 negative PCRs. And this picture, CMV pneumonitis, looks like bronchopneumonia, but remember it's associated with high mortality. Bronchoalveolar lavage will show the characteristic owl eye of CMV inclusion bodies. So risk of recurrence of CMV, primary infection. So D positive, donor positive, recipient negative, associated with risk of recurrence. Multi-organ disease associated with hepatitis, nephritis, pneumonitis, risk of recurrence. High viral load, we need to know the log, how many copies, associated risk of recurrence. This is why we need to extend the prophylaxis. Resistant CMV, so slow reduction in viral load with treatment, increased risk of recurrence. Persistent viremia, of course, this is not recurrence because the disease hasn't gone. The worst case scenario, if the organ is rejecting with CMV because you give immune suppression. This next one, which is the last slide, these are suggested readings. And the next one is the British Transplantation Society guidelines for CMV disease. Is, if you notice, July 2015, so it hasn't changed that much. And thank you very much, and apology for the electronic glitch, but this is beyond my ability.
Thank you very much, Professor Halawa, for this very nice and very simple presentation for CMV. You bring it very simple. I'd like to start with Professor Qosi, then I'm going to have a few comments. Dr. Qosi, please unmute yourself.
Thank you very much for this nice presentation. I probably defer myself to the rest of the people. So if there is any comment from the floor, because I have seen interesting comments from the floor, to be honest. And I would like just to wait until to just hear from the others. Is it okay?
It's okay, no problem. You are the boss, so as long as let me just to have comments on this presentation. It is, as I mentioned, it's very simple approach to CMV, and the part of invasive CMV is very nice as well. Regarding the issue of prophylaxis, in the past we didn't give prophylaxis for our patients for CMV, and when we reviewed the literature, 1/3 of the transplanter didn't use prophylaxis, so it is not a crime not to give prophylaxis. But if the patient is induced by ATG, it is mandatory. If the donor is positive and the recipient negative, is mandatory. If the recipient is positive, the only status that doesn't indicate prophylaxis, which is very rare to have D negative, donor negative, and recipient negative, and it is very, very rare, because as Professor Halawa mentioned, when we age, the CMV positivity is very common, more than 70% in immune competent and up to 90% in hemodialysis patients. So at the end of the day, it is very rare to find donor negative and recipient negative as well. The second point regarding prophylaxis, valganciclovir is expensive. So when we address, because we had a couple of cases of pneumonia, so then we discussed how to use prophylaxis. We decided after the meeting to give not valganciclovir for all. Valganciclovir is reserved for D positive recipient negative, but we used valacyclovir. Valacyclovir is cheap, available, and when you use this drug, we used the bigger dose, 8 grams per day. We witnessed side effects, high liver enzymes. So by time we reduce the dose into 50%, 4 grams valacyclovir. And then since 3 years, we conducted randomized controlled trial. Sample size is small, 30 patients in each arm. So the patients either treated prophylaxis by valganciclovir, which is valsite, but we used the low dose because some centers used 450 milligram, not 900 milligrams. So we compared 450 milligram daily to valacyclovir 4 gram. And the results of 6 months were presented in the ESOT 3 years back. No difference between the two arms with marked cost reduction. And the ISN, this ISN, which was not conducted because of the corona, but the abstracts were published in Kidney International Report this year. We sent the abstract of 3-year follow-up. After 3-year follow-up, no significant difference in the rate of infection or rate of CMV disease, although we used cheap drugs. So this is the evolution of the prophylaxis at our center. And we observed marked reduction of CMV pneumonia by using this regimen. And I read one of the articles last year in the American Journal of Transplantation about a very exciting issue, relationship of valsite, valganciclovir, with increasing rate of BK. So valganciclovir, even if you criticize this study and you say it is not fantastic, but this is the American Journal of Transplantation showing that it is valganciclovir is associated with BK. So it reduces CMV, but increases BK. And valacyclovir that we used is not associated with increased risk of BK. So we like valacyclovir. It is very cheap and worked well with us. This is what we do. The last point before I'm leaving the floor, the mic, up to this moment, there are 2 strategies, either to give routine prophylaxis or to adopt preemptive prophylaxis. Preemptive prophylaxis means to follow PCR frequently until we have positive, and there is cutoff point. If we reach the cutoff point, as Professor Halawa mentioned, we start giving a valsite. So this is the way, either to give it as a prophylaxis routine or preemptive treatment if the PCR changes from negative to positive. Do you want to comment on the preemptive school, Dr. Halawa?
Yes, preemptive schools means frequent PCR, patient compliance as well. So in a center like yours, covering the whole country, I don't think preemptive prophylaxis, will help much because, sorry,
we are not covering
how compliant your patients, because I've seen some of your patients coming from here and there, from everywhere. How compliant your patients? How often they come for follow-up in your clinic?
Okay.
Also,
Do you ask me?
oh yes.
Yes. First, we don't cover all the country. We're sharing now few sector of transplantation. Transplantation is mainly in Cairo. And in our center, we have CMV PCR, quantitative, so we don't have it positive and negative. We have quantity of CMV, and we calculate the log and whatever you mentioned. So our patients are compliant for follow-up because lab and dispensing medication is from our center.
Yeah.
So this is, and as I mentioned, yes, our rate of transplantation per year is 120, and the transplant program is logged from March. And if I say we transplant 120, Egypt transplant more than 1,200 kidney transplant per year. So yeah, our patients are keeping compliant with follow-up, and we have all the facilities. But we don't like preemptive school because it needs frequent PCR, and valacyclovir is cheap drug, and I think we are successful. You can criticize our randomized controlled study, 30 patients in each arm. I agree with you, but since many years we use valacyclovir, and the rate of admission to the hospital is significantly reduced. We don't have fatal pneumonias anymore. So since 2009, so I think it is successful.
Yeah, don't forget you used the small dose of valganciclovir, which is 450. The right dose should be 900, provided the kidney function.
There are some centers using for prophylaxis. There are some centers using the low dose. Even the low dose, 450, is expensive if we give it to mass of patients. This is why we use the more the cheaper drug, which is valacyclovir.
To be honest, I have to be objective. We have to consider the resources as well. Yes. I mean, guidelines are just guidelines and designed for somebody else somewhere else, under the sky, not necessarily to apply to you, but you have to use your own guidelines within your own resources. I totally agree with you. If it works for you, reduce the number of fatal CMV pneumonia. It did work. This is good. This is good plan. This is good policy. Cheap because my understanding, you pay for the medicine. Your center pays for the medicine, but other places that the patient pays for the medicine. Is it right?
The patient doesn't pay here anything. There is coverage. I think in Egypt there is coverage from insurance because the immunosuppressants are available in insurance, and we add to the insurance if we have a special treatment, special case, we cover.
Yeah, so it's a burden on the country. Yes. Okay. If it works, it works. Yeah, there's no comment. Guidelines, just guidelines.
Yes, Professor Yasser Hamid.
Thank you, Professor Ahmed, for this highly elegant talk. I have a number of questions, please.
Please go ahead.
Excuse me. I want to ask about your experience about treating infection, CMV infection, not disease, just only by lowering immunosuppressive dose and stopping antimetabolites. Does it take place?
I think no.
Look, both together will reduce immunosuppressive dose. Yeah, and in addition to the antiviral treatment, valganciclovir.
In addition to antiviral treatment.
Yes.
And this is, you said that you do not take actions except CMV is 3 logs, more than 3 logs.
Right. That's right.
Or any measurement of. So if CMV PCR is less than 3 log, this means that we are not to take any action if there is no symptoms, no.
I mean, reduce. No, I mean, no action. I think you misunderstood me. No action in terms of antiviral treatment, but to reduce immunosuppression. If you have 1 log.
And this is my question.
If you have reduce immunosuppression, let's just stop that antimetabolite and see how it goes. Don't forget, valganciclovir is a nephrotoxic drug.
Yes.
And it's a burden as well, financial burden. So we'll see how it goes. I'm not treating this patient with sweetie. This is toxic drug. And monitoring the patient as well, more important. If you see that your response, there's no good response to reducing immunosuppression, you shouldn't wait for 3 logs to happen. You should start antiviral treatment.
Yes, and this is my question. It was clear that less than 3 logs, we just reduce anti-metabolites, stop anti-metabolites, and reduce immunosuppression. More than 3 logs, we are to go to active treatment.
You have to do both, yes.
Right, okay, thank you. So my second question, that if we assume the question, the scenario of Professor Hussein said in the start of first case, that we are in the start of transplantation and are giving MMF 1 gram PID, and we have CMV. The CMV is treated, and 2 PCRs are negative. What is the dose to return for CMV for MMF at that time? Is it the same dose of high dose of 1 gram PID, or we are to return to reduced dose?
Look, I mean, this is a very interesting question, and there is no right or wrong answer, but there is common sense here. So, CMV means patient is heavily immunosuppressed.
Yes.
I should take the message that this patient was heavily immunosuppressed, so I have to reduce his immunosuppression after treating the CMV. So I may not start MMF at all, but it's high risk transplant. I might give him half the dose, which is given 500 milligrams.
Half the dose, even in high risk transplant.
Absolutely, yes. So, but all signs and symptoms indicates that the patient is over immunosuppressed, and this is why he got the CMV.
Yes.
There is T cell dysfunction, so I need the T cell to recover by lowering immunosuppression. And we prefer not to play with the CNI, but sometimes we do. But most of our actions based on anti-metabolite MMF, we stop it or reduce it after treating the acute infection.
And in the case of recurrence in this high-risk transplant, do you agree
Dr.
that
Yasser,
we are to stop?
Dr. Yasser, excuse me, regarding the dose of MMF, if the patient is treated with tacrolimus, there is synergistic effect between tacrolimus and MMF. This is why if the patient is not high immunological risk, or if the patient just recovered from CMV, so he is suppressed, 1 gram, total 1 gram per day MMF, or equivalent to my Fortex 720, is enough with tacrolimus.
Yes.
To put this in mind, even if there is no CMV, we don't give 2 gram except for 1 month or something like that, and then 500 milligram twice a day, so long as the patient is intact treatment, because there is synergistic.
This period, yes.
Yeah. Okay.
Yeah. To be honest, we're talking about CMV. We're at the height of immunosuppression. So basically, in the first few months after transplantation, he was receiving full dose of TAC, full dose of MMF, and full dose of steroid as well. And then we reduce the immunosuppression as we go along. But I'm answering your question regarding the dosage of MMF. If you have CMV, you stop this the MMF completely till you treat CMV, and then introduce half the dose or no CMV at all. And this is actually, no MMF at all, but you need to know the matching. You need to know the immunological status of the patient. Is it immunological high risk or not? So high lysocytosis with PRA 100%, and 2DR mismatch. This is immunological high risk. Second transplant, third transplant, fourth transplant, previous rejection before. So this actually, it will highlight the importance of this patient may have immunological damage if you play with immunosuppression not carefully.
Okay.
Last question. Okay. Thank you, Dr. Yasser, very much.
Thank you. He answered the question. I answered the question between his talks.
Thank you very much.
Thank you. Thank you, Professor.
I'd like to hear Professor Faisal Shaheen.
Thank you very much. Thank you. Excellent, Dr. Halawa. Your presentation is very clear. And I think I have no comment. Probably we are taking the same way of Al-Mansoura, that we are giving a lowest dose of Valsite, and we don't have any problem so far. But we have few cases negative to negative, so I don't use Valsite because some of my patients are they are, you know, they can't offer to buy the medication for longer time. So I agree with the point you mentioned, and it's excellent and straightforward talk. Thank you very much.
Thank you, Professor Faisal. If the patient, the donor and recipient are negative, there is no indication at all for prophylaxis. Yes, I agree with you. But I remember here a point. One of the pitfalls that some physicians do is depending upon IgM for saying positive or negative before transplantation. If the patient is on dialysis, we depend upon IgG, not IgM. So seropositivity is dependent on IgG. And after transplantation, we use PCR. Am I right, Dr. Halawa?
Absolutely. IgM is for screening.
Yes.
Sorry, IgG for screening. IgM means acute infection. But, you know, this is the standard for transplant workup. You know, there's IgG. Yeah, this is screening. But monitoring, you need level, you need how many copies, you need to know by PCR. Not CMV antigenemia or PP65, puffy coat.
All these are old-fashioned.
All this gone, yes, all this gone for many reasons. One of the reasons, you know, this, you know, antigenemia test, you need freshly prepared sample. So it has to be processed within 6 hours. But the PCR, you can't put the sample in the fridge and do it next day morning. You can send it somewhere else to be done. You know, so the PCR, however, is more expensive, more reliable, as well as accurate.
Okay. So why IgG? Because all of us take the infection in the early childhood, and the first immune response is IgM, and then by time it is IgG, shift to IgG. So there is no wise at all to depend upon IgM. And then saying the CMV is negative. No, the CMV is positive in more than 90% in the recipients in dialysis. So this is why there is some trick in those who are depending upon IgM. It is better not to request IgM to know the positivity or negativity before transplantation. After, as Professor Halawa mentioned, PCR in quantity. Dr. Dina Abdellatif.
Thank you, Dr. Halawa, for this wonderful presentation. And you've mentioned that you give prophylaxis, and I assume you give prophylaxis for all your patients. And you mentioned that you extend it for those high-risk group. So would you please clarify what do you mean by this high risk? Or maybe the protocol is somehow different than...
Sure. Yeah, all patients...
And for how long?
Yes.
And the dose for the prophylaxis that you're using after treating cases or...
For us, it's quite straightforward. D negative, R negative, they don't take any prophylaxis. Yeah, because, you know, they are negative. Yeah. But the highest risk when D positive, donor positive, recipient negative, this will have an extended prophylaxis for 6 months, 200 days. Yeah, we know that even after we stop treatment or prophylaxis after 6 months, they might get CMV. We keep monitoring them for CMV every 3 months. Also, those who are high risk who received strong induction, ETG or Campath, alemtuzumab. When we started using Campath, this was a few years back, we didn't think, it's our mistake, we didn't think of CMV prophylaxis because we don't know the drug that much. And we discovered that all patients got CMV. All patients received, was part of that trial, 3C trial run by Cambridge. We discovered that all of them got CMV. So we started to give them prophylaxis as well. So any strong induction, so extended prophylaxis for 6 months. We are aware after 6 months, they still might get it, but of course the incidence will be much less and will be monitored. And I would like to tell you a secret, we're not paying for the valganciclovir. The unit are not paid, is paid by the NHS. So I'm not worried about the cost. This is why we're liberal with the medications a bit.
So it is 100 days or 3 months. because this is the limited resources, except if the patient has rejection and treated with antibody. This is what we think.
And
But,
when
200 but I don't accept 200 days because it's too, as prophylaxis, because it is very expensive.
yeah, I mean, but, as I mentioned, we're not paying for the valve
Yes.
there. The NHS is paying for it, but it's been shown based on our studies, based on our audits as well, there is still recurrence after, you know, after 100 days for high risk. So we extended the prophylaxis for 200 days.
Okay.
Even if you extend it even for more, you get less CMV, but again, this is not cost effective.
Thank you. Yeah.
Dr. Mohammed Saeed.
Thank you, Professor Halawa, for this elegant lecture. I would like to see that what you mentioned now regarding the duration of prophylaxis. The main issue now in the timing, is it 6 months, 3 months? Still, we see some patients after completing 6 months for the positive R negative or 3 months for R positive, still they have relapse. What do you think about using the new test of CMV specific T-cell immune response by ELISA and the kinetic from pre-transplant to post-transplant to know exactly when to stop the prophylaxis? Yani they did in certain centers in the states the CMV specific T-cell response, examining CD4, CD8. Once it is positive at 90 days or at 6 months post-transplant, at that time they are safe to hold or to stop the prophylaxis to avoid relapse again. This is my first comment. The second comment, do you think that the PCR till now, even after standardization by the international unit, still we cannot use a cutoff value for clinical correlation? Yani we don't have a cutoff value to say this patient might have asymptomatic infection. This patient might have latent infection. This patient might have CMV disease. This patient might have in tissue invasive. But still we have a problem with the PCR regarding the clinical correlation. The third one, do you think about patient going for combined transplant like liver and kidney? If they have G positive R negative, do we have to change the dose and duration of treatment because of the higher volume of virus exposure to the recipient or not? The last one regarding the resistance. Do you think before we go for Foscarnet, we might increase the dose of antiviral before shift to the Foscarnet? And thank you so much.
I think Dr. Halawa didn't remember. Didn't capture it.
We can.
No, regarding I think regarding the advances in immunology, it is dedicated for some places and not a generalized policy. The second point, the PCR.
The second point, the PCR and its clinical correlation.
It's a correlation. Is there a good correlation between the titer of
and the clinical,
or log of CMV and the clinical presentation, the clinical outcome of the patient?
So say it again. What's the question?
And the cutoff value for the PCR. Yani we can know this is positive, this is negative, this is high, this is low. But to correlate the cut value with the viral load with the clinical presentation.
Can you predict
the
invasiveness of the disease that will occur based upon the level
PCR.
of PCR?
Yes.
Of course, you know, the high is common sense. The higher the level, the more invasive disease you will get, the more severe symptoms you will get. So it's level related. There's one slide which I deleted. I thought it's too much because it's common sense. So the symptoms is related to the viral load. And also the degree of recurrence, the incidence of recurrence is related to the viral load. Also, if the tissue invasive CMV and the PCR is positive is related again to the viral load. So it's all about
sometimes we see patients with low viral load, they have tissue invasive. And other with higher viral load, they have milder disease.
Look, nothing is 100%, you know, it's not a rocket science. And if you remember the first slide in tissue invasive, I said gastrointestinal CMV is an imperfect science. So you have to correlate everything you have. You know, nothing worse than having symptoms and viral invading the tissues and PCR is negative. So it will tell you that you have to have a holistic view about clinical signs, the symptoms, the viral load, the donor and the recipient serostatus, the immunization of the donor means, you know, if it's exercise or not. So all this together. So there's nothing in medicine is cut off. Nothing is called cut off because, you know, you can have confounding factors all the time.
The last point, Dr. Muhammad, do you have?
The combined like liver and kidney.
Is there a relationship between combining organ transplantation with
and the volume of the virus to change the dose or duration? Is it different solitary kidney transplant from a patient who has liver and kidney with D positive or negative?
Right. We transplanted kidneys after heart, we transplanted kidneys after liver, and we know that, but you know, they transplanted a year or 2 years down the line. What happens is, because this is an extensive talk, what happens if the kidney fails secondary to immunosuppression, secondary to CMV? So they pass the period of infectivity, but we know they are positive. You treat them, we treated them as if they are kidney only because the other organ quite stable. And don't forget, you have PCR to monitor, you have clinical symptoms to monitor, and you have invasive investigation to do if you suspect tissue invasive CMV.
I think it is rational because the drugs, as Professor Halawa mentioned, are toxic. And I remember a study correlated the valganciclovir with some histological change in the graft. So this is a cost balance. So at the end of the day, we monitor PCR. But I remembered not all immune suppressives are bad guy for CMV. The only class that it is friendly with CMV is mTOR inhibitors that Professor Halawa doesn't like. The mTOR inhibitors are associated with significant reduction of CMV because they are anti-proliferative and they suppress the viral proliferation as well. So as shown in the majority of randomized controlled study, either in the everolimus or sirolimus, CMV is less with these drugs. And also BK, there is tendency in the past in the some systematic review and meta-analysis, and currently in transform study, BK is significantly reduced by everolimus. But Dr. Halawa don't like this class and he doesn't use them in immune suppression.
I will tell you the truth, because you know I made my presentation based on our practice rather than academic from textbooks. None of our patients now already on mTOR inhibitor. None. We were found of mTOR inhibitor when it was introduced. We thought it's not nephrotoxic, as you know, we can improve the graft survival, and this proved actually not true because the dropout rate was very high, very, very high, and even patient with cancer. You know, we operated on transplanted patient with skin cancer and basal cell carcinoma and all sorts of things. And we gave them mTOR inhibitor. They stopped taking the treatment because of side effects of the drug. So it's pointless for me to present a work which we don't do because mTOR inhibitor is associated with extensive side effect. How many patients in your center have mTOR inhibitor?
We have a good volume of patients because we have multiple randomized controlled trial, and this was one arm, and we published I think 15 years follow-up for sirolimus, and nowadays we are waiting the collection of the data for everolimus study, and we use everolimus for de novo. And the sirolimus de novo in the last randomized controlled study that we are collecting the data. So we have good volume of patients treated with mTOR inhibitors, but we shouldn't think that mTOR inhibitor to be taken as primary prevention for CMV, but it is one of the advantages of this class of drugs. Okay. We have 5 minutes and stop. Dr. Saeed Khamis. 5 minutes, and then Dr. Mohsen will take his time for comment and then stop. Dr. Saeed.
Thank you, Professor Hussein, and thank you for Dina and Dr. Elsalamony and Professor Halawa. I have nothing to comment actually, but I would like to thank all the professors. It was very fruitful meeting, and I hope, inshallah, it will be again and again to meet in such very fruitful meetings. Thank you so much.
Thank you very much, Dr. Saeed. Dr. Yasser Al-Mulla.
Many thanks. Elegant talk. Few comments in less than 2 minutes. So at Edinburgh, we follow exactly the same protocol that's mentioned by Prof. Halawa. And it's interesting to say that we do the resistant profile for every patient, and we do send it to Sheffield because it's the only viral lab which does the resistant profile in England. We exactly follow the same protocol for everything. The only thing which probably not mentioned by Professor Halawa, but probably is already followed, that if we have a patient with a steroid-resistant rejection and we end up giving ATG or Campat, let's say a year or 2 or 3 after transplantation, we end up repeating the whole prophylaxis regimen as already mentioned, because this is regardless of whether the CMV PCR is positive or negative. One of the audience asked about the combined liver and kidney transplant. So at Edinburgh, we do combined liver and kidney at the same time, about 15 to 25 cases per year. And the protocol is exactly the same as mentioned by Professor Halawa. Professor Halawa on his second slide showed a very nice map of the body with sites of the CMV. And I saw a case that I will never forget ever. It's a patient who had a very stable transplant function, a couple of years of transplantation, presented with an aneurysmal fistula, which was angry looking, and the aneurysmal part was increasing in size. And because his kidney function was very stable, he ended up having a surgery. So he had like a ligation of the fistula with a resection of the aneurysmal part. And on pathology of that, it came back positive for CMV. And it was very convincing, despite that the patient had CMV PCR negative in the blood. And it was the only site where he had the evidence of the CMV. It was available and evident on the pathology of an aneurysmal resected fistula a couple of years after transplantation. And I learned one nice phrase from Professor Halawa, which he didn't mention today, that one size doesn't fit all. So I'm aware that at the Royal
Dr. May, please.
Yes. First, I'd like to salute all our eminent professors and dear friends. And thank you very much, Professor Halawa, for this very informative talk. And actually, one of the best articles I have read was the one by Professor Halawa in the Egyptian Society of Transplant Journal on post-transplant infections. And you mentioned, Professor Halawa, that you treat for 2 weeks after clearing the virus, the CMV, and then you continue on. You continue more prophylaxis after that, after the 2 weeks.
True.
And
Yeah.
and for how long the prophylaxis after treatment?
It depends on the donor positive, donor recipient serostatus. If serostatus D positive are negative, I will continue for 6 months prophylaxis.
After treatment?
After treatment.
Yes.
If
okay.
both are positive, we'll continue for 3 months.
Okay. And you agree that patients with repeated CMV should be maintained on prophylaxis forever?
Ideally speaking, the longer prophylaxis you give, the less likely to get the CMV infection. But practically, again, the prophylaxis, valganciclovir, is nephrotoxic, isn't it? Associated with a lot of toxicity as well in terms of the white cell count and all sorts of things. And even the study, impact study, because it was organized by Roche. It's one of their advantages to sell the drug. So they extended the prophylaxis to 12 and 24 months. I don't think this is in real life applicable. I would say the longer, the better. But the longer for us is 6 months. You can say, 4 months, you can say, but the principle is the same. The longer, the better. But we're not dealing with, with safe drug without side effects.
I just want to say, thank you very much, Professor Halawa. I just want to say 2 comments. One is that in the work of tissue invasive disease, CMV, like in diarrhea, the trend was when the PCR comes negative, you start thinking of something else. Now, what we really gain from this this whole symposium is that you should not, and you have to continue investigating up to colonoscopy after excluding other causes. So this is very important. And one of the interesting comments that I saw on the chats is that the metronidazole has been removed from the guidelines for the treatment of Clostridium difficile. So I'd like to hear your comments about that.
We use vancomycin.
Directly, without
directly.
Okay. Thank you very much.
Thank you very much, Professor May. Dr. Yasser Al-Mulla, we lost you. If you please yes.
I'm very sorry. When did you lose me exactly? At which part?
Yeah, so at Edinburgh, you have a good experience in combined liver and kidney, and you follow the same approach, giving.
Follow exactly the same.
Yes.
Exactly. So we do the liver and the kidney at the same time, and we follow exactly the same protocol as mentioned by Professor Halawa during the presentation.
And then you mentioned the fantastic case of the fistula, and the only is aneurysm of the fistula, and by biopsy of the removed aneurysm, you find the CMV. Did you treat the patient? Did you publish the case? What was the fate?
It was published as a poster in one of the ATC. It wasn't published by me. And there was a discussion whether we need to treat the patient or not. Sadly, we have clinical virologists who are always trying to put their nose into our cases when they get the lab result first. And they were very adamant that we must treat the patient. So yes, we do treat. And the other thing that our clinical virologist here does is that every single patient with a CMV positive PCR, they send for a resistance profile. In the whole England, it's only done in Sheffield. And the other thing is that they're very much interested in Cidofovir because it's an oral option for those who are Valgan resistant. But we always follow the same protocol as mentioned by Professor Halawa, that's like, rather than what they say. So we go for IV foscarnet for the resistant cases. At one phrase that Professor Halawa used always to say, which he didn't mention today, is that one size doesn't fit all. So Oxford, they follow the same protocol as mentioned by Professor Halawa. At the Royal Free Hospital in London, they don't give any prophylaxis, even for CMV D positive to R negative. They don't give a prophylaxis because they have a different population there, and the compliance is an issue, the neutropenia is an issue, but they do like intensive screening by the CMV PCR. At the Hammersmith, they follow the same protocol as mentioned by Professor Halawa, but the maximum dose of prophylaxis is 450 milligram daily rather than the 900. Professor Hussein, you mentioned about the valacyclovir versus the valganciclovir, and there was a paper published in CJSON, if I'm not wrong, in either 2014 or 2015, which confirmed what you said. It was from the Czech Republic, but the number of patients was relatively small. I'm not aware about any center here that use the acyclovir for that. And the last point, which I did mention, I'm not sure whether you heard it or not, is that apart from what's already mentioned by Professor Halawa, is that if we have a patient with a steroid-resistant rejection and we end up giving either Campat or ATG couple of years after the transplant, or if we have a case of PTLD and we end up treating with rituximab, regardless of the CMV mismatch or the CMV PCR, we end up repeating the prophylaxis course as mentioned and as presented by Professor Halawa. So let's say a patient 10 years post-transplant, stable graft function, evidence of PTLD, treated with rituximab, we end up giving the valganciclovir prophylaxis again. I'm not sure whether they do the same at Sheffield or not.
Yes, any history of aggressive induction or aggressive immunosuppression dictates that extended prophylaxis.
Not induction. He mentioned if you have rejection after a couple of years.
Or aggressive immunosuppression.
Yes.
Any aggressive immunosuppression.
I think it's rational, yes.
Yeah, it indicates that extended prophylaxis.
Yeah, so I did mention the steroid-resistant rejection when we give either ATG or Campat. That's when we end up, as mentioned by Professor Halawa. Excellent, thank you.
But regarding the point of valacyclovir, the paper that I referred to you, comparing the PK in valacyclovir treated, when we read the details of CMV, and it seems that valacyclovir is working well. So this is cheap and working well, and they need monitoring. It's okay. And for those who are not applying the policy of prophylaxis, as Dr. Yasser Al-Mulla mentioned, they monitor the viral PCR as preemptive school. Am I right, Dr. Yasser?
You are absolutely right. And to be honest, at Edinburgh, despite us like following the prophylactic protocol, we still have a protocol for CMV monitoring. So even if you're on prophylaxis, 900 milligram daily with a normal graft function, we end up checking the CMV PCR monthly in the first 6 months, then every 3 months following that, then every 6 months after 3 years, even with no previous history. So we do follow both rather than one of them. And as I said, we had a few cases in the last 2.5 years of CMV disease in cases of transplant where there is a mismatch. It's a CMV donor positive to recipient negative. Despite being on the appropriate dose of prophylaxis, they developed CMV disease with tissue invasive, and they turned to be ganciclovir and valganciclovir resistant, and we end up giving them foscarnate.
Thank you very much for all your comments. They are very nice comments. And Dr. Yasser Al-Hamid raised the hand. Dr. Yasser.
Thank you. I just one comment, just to agree with you totally, Professor Hussein, for valganciclovir that we used in some cases in our center and with success in prophylaxis in the view of limited resources instead of valganciclovir. And this is was my last comment.
Thank you very much, Professor Yasser. I remember a randomized controlled trial published last year about comparing preemptive to the routine prophylaxis. And I think, I'm not sure from the data that it showed and confirmed superiority of prophylaxis to the preemptive treatment. Dr. Kosi, we are eager to hear from you.
Thank you very much. I realize that now we are too late, but it's just only just as you can see, the preemptive versus prophylaxis, it is all depending on the local logistics. Okay. You can see from the UK itself, we have got the guidelines, but still you can have differing views about the way that we are treating or prophylacting these patients.
And your opinion, or if you have the both facilities to monitor PCR or to treat, do you prefer routine prophylaxis?
Yes.
Yes. Okay.
Yes. Yes.
So we agree about this point.
Yeah. Based on the same paper that you mentioned just now.
Yes. Okay.
The second point is I was perplexed by the case of Dr. Dina Abdellatif as a cause of the cerebral hemorrhage. I was very interested about this case, and I can see one comment from the floor. It could be a perianeurysm from a patient who has got adult polycystic kidney disease with severe hypertension, which could be acceptable explanation to what's going on. So this is very nice thing that is being commented from the floor. The third point is if there is any correlation between the PCR level and the clinical severity of the patients. Generally, there is no cut-off for this to say that this is an infection, this is the CMV disease, or whatever. And you can see that there is still tissue invasive disease without any PCR, or it is negative completely. So we usually rely on the trend. If the level is very low of the PCR, we monitor. If the trend is increasing, we need to interfere. Sometimes we just wait, and we are very restrictive that the patient is only on CNI, and we can't reduce the immune suppression anymore. So we have to treat. So you need to take this into account when you are looking.
So which cut-off point do you follow?
To be honest, if the trend
is it 400 or a trend only?
As the trend, we are looking into the trend, not only one single figure. If the trend is going by weekly monitor of the CMV PCR, then we interfere by treating.
But if the patient is manifested clinically,
straight away,
yes,
you don't need to wait. So
okay.
I've got two things: a patient who is not symptomatic, and you have got CMV PCR positive, but at a low level, and I don't have a threshold of what does it mean a low level, but he doesn't have clinical symptoms. I will just monitor weekly. If the trend is going up, I will interfere by reducing the antimetabolite, or if he is not on antimetabolite, I will give the valganciclovir.
Do you have any experience with IVIG, CMV IVIG? Because I expected that it may help in invasive lung, like severe pneumonias, to give IV ganciclovir plus IVIG specific
for. To be honest, in exceptional cases, usually in the ITU setting, when you have got the patient on CNI and you don't like to stop the CNI simply because you are going to lose the graft. So you don't have any alternative, and he is not on antimetabolite, has been given the ganciclovir IV, and they didn't respond. You don't have any other alternative. So you need to give the IVIG as a last resort you have got in your hands.
But it is not the regular IVIG, just
No.
to clarify. It is
No, it is the regular IVIG. We don't have the CMV specific IVIG.
What I mean is CMV IgG, because IVIG in general, we gave it already to a couple of cases. We have severe infection and not CMV, it is other infections. So IVIG can be used in severe infection as a double-edged weapon to sustain the graft,
and
to
this is what we use.
Immune modulation and to reduce immune suppression.
This is what we use. We don't use, CMV specific IVIG.
Okay.
And this is what I mentioned, the case I presented, we didn't have CMV IVIG at that time. So we used the usual IVIG.
And we don't do this.
It didn't work very well.
Okay.
It's only one case.
And we didn't do these fancy immunological T cell specific CMV or all these sort of things. We don't have that. Okay. We just do the routine CMV PCR. The last thing is about the identity of the patients. I believe that many patients can be described as Hispanic, Afro-Caribbean without any problem. I'm not sure, to be honest. I have to look into that because, the nationality is not a part of the identity. It's probably just the date of birth, the patient name, all these sort of things. But the nationality, I'm not entirely sure. We need to, to look into that. Because as I'm saying, a case report, you can write down this patient has got Hispanic background, Afro-Caribbean background, without any...
When I say the race, I say the race if we present a patient to the senior in the clinical round. But in our Zoom meeting here in Egypt, I don't like to say Kuwaiti, Saudi. This is a patient.
No,
so long as this information will not aid anything. So why I say Egyptian patient if it doesn't help anything in this educational event?
I'm just trying to define what is, part of the patient identity or not part of the patient identity. Okay. I believe the nationality might not be part of the patient identity, but the date of birth, the patient name, all this is for ethical reasons and confidentiality reasons. I believe this is part of the identity. I have seen also one comment lastly in the floor that's saying that the metronidazole is no longer be part of the guidelines, and there is a JAMA article. The guidelines, it is a guidelines. It doesn't mean that you don't need to use it. Our protocol is to use the metronidazole because still we have got many C. diff patients sensitive to the metronidazole, which is very cheap. If you have got in your locality that the C. diff patients, they are resistant to the metronidazole, yes, go ahead with the vancomycin. But to be honest, we use the C. diff metronidazole and they respond very well without any problem. So
he wrote here, it is also adopted by NICE and our SMID section in May 2020. So this is,
I'm trying to say what we are using locally. So to be honest, what we are using, we start with the metronidazole still. We don't use fearing the resistance of the vancomycin. Because if we have got resistance to the vancomycin, we have got only the other option is daptomycin. And daptomycin is very, very expensive. The course is 1,200 pounds, which is too much. So this is, thank you very much. I don't think that I've got any more to add.
Okay, I think now we are late and we should stop. And I would like to have the opportunity of presence of Professor May Hasaballah, the President-elect of the Society, to close this session. Unmute yourself, please, and conclude, Dr. May.
I believe everything has been said already, so I just want to thank each and every one of you, and of course to thank you, Professor Hussein, for this excellent work and continuous level of care that you're giving to this Zoom meetings to go on. Thank you very much for everything, really.
Thank you very much, Professor May. Thank you very much, Professor Halawa, Professor Qusi, Dr. Dina, Dr. Tamer. Really wonderful and fantastic night. And Dr. Halawa, do you like to say hello or goodbye?
Actually, yes, I would like to say hello and goodbye, but just one thing I would like to conclude. One size does not fit all. It depends on your local resources. It depends on your population you're treating as well. So myself could be different from you, but what we have in common, monitoring the patients, tailoring the treatment based on our patient population, based on our resources.
This was my comment. This was my comment on one of the giant professors in the field of infection, post-transplantation in the United States, when she delivered the elegant presentation about infection after transplantation. And she mentioned a lot of infections and how to monitor. I said to her, it is the local policy. So infections which are common in the United States may be not common in Egypt. There are common, but there are some peculiar infection in each place to be searched. So I agree with you 100%. One size doesn't fit all. And it is our responsibility to evaluate the patient, good history, examination. It is not only PCR, because PCR alone doesn't tell us everything. So clinical, PCR, this is our job. So after 2 and 45 minutes, we should say thank you very much, Professor Halawa, Professor Qosi, Dr. Dina Abdellatif, Dr. Tamer, and Dr. Faisal Shaheen. We enjoyed your presence. And needless to say, thank you very much, Professor Maya Hasaballah, for your presence. Really, you add a lot. Thank you all. Goodbye. And inshallah, I'm going to upload the video tomorrow, inshallah.
Fine. Thank you very much.
Thank you very much. Goodbye.
Goodbye.